Good morning, friends. It gives me great pleasure to be part of this preconception management workshop under aegis of Maternal and Fetal Medicine Committee of AOFOG. And I must say big thanks to our chairman, Dr. UDP Ratnasiri. I must say big thanks to AOFOG President, Professor Kazunori Uchiai, the chairman of Indonesian Obgyn Society, Eri Kusuma Janoarto, the chairman of the Congress, Professor Endon Hestiantoro, and also the Indonesian Maternal and Fetal Medicine Committee chairperson of the Indonesia, Eri Gumilar Dechian. I'm very sure chairmen will agree on this particular fact that certain molecules play a major role as far as the preconception management is concerned. And that's why I wanted to come, in fact, in physically for this particular Congress, but as I need to travel next week for another Congress in Punta Cana, West Indies, and then it was too much of travel. So I decided to be there virtually, but I'm very much with you all for this particular event. We all understood that this preconception management is very, very important. And there is an increasing tendency to emphasize that female age is one of the main factors which affects fertility. The average age in which the first child is sought has moved by around 10 years in the past 70 years, and it is a fact. The complex factors of social transformation that are seen in the family organization and the role of women radically change in 50 years, completing their studies, looking for satisfying job, consolidating their relationship, and planning a child today led the search for pregnancy in the fourth decade of life. Now, we know that amongst the best, the studied was the neurological defects, the main risk factors for the fetus if there is deficiency of certain substances like folic acid or the inositols. Similarly, we know about these women which were described, these girls who were described, association of enlarged sclerosistic ovaries with amenorrhea, infertility, and hirsutism, very well said as a diabetic desphemobabie. And that was nothing than the PCOD or the PCOS affected or the diagnosed girls or the women. And that's why when the girls come in front of you in your OPD, in outdoor patient department, your office, you always need to put a lot of actually work in that, insight in that, to avoid all those problems related to the polycystic ovarian disease. The adjuvants play a major role in the management of that. The purpose is to suppress endogenous pituitary gonadotrophin and ovarian activity and to reduce the insulin resistance. These are 2 to 3 months OCs, generic japonis for 6 to 8 weeks, exogenous insulin or insulin sensitizer like metformin and dopaminergic agents, progestins in second half, and steroids, and of course, the lifestyle changes. We know these various options as well as the improving actually the effect of various combinations which we use. But we need to take all those things comprehensively and where exactly the inositol plays a major role. We need a drug therapy which improves the insulin's action completely and also manages the syndrome comprehensively. And that's why the B8, that is inositol, and B9, the folic acid, plays major role. When we see that fix those combination of these two particular molecules is a new therapy option in the PCOS. Myoinositol and folic acid is an evidence-based combination that increases insulin's action completely, and it also ensures the ovulation for women who want to conceive. It is also known as vitamin B8 and its chemical structure is as follows. Similarly, folic acid is also known as vitamin B9 and its structure is this way. But it improves insulin action and ensures ovulation by which mechanism? That is more important question one need to understand before utilizing it in our day-to-day practice. The normal mechanism of glucose entry in the body cells, where we know that this phosphatidyl inositol, that is 3 kinase production and activation is essential for insulin to act. And this PI3 kinase production, one need to understand how actually it involves various enzymes and various steps as well when it reaches to the receptor level. In PCOS, the production and activation of this PI3 kinase is reduced. In PCOS, myoinositol deficiency is also documented. And that's why it is required to produce an active PI3 kinase to improve insulin action and ensure ovulation. Elevated concentration of myoinositol in human follicular fluid plays a positive function in follicular maturity and provides a marker of good quality oocyte. In our IVF practice, we always notice this particular fact. Myoinositol plays a fundamental role as a second messenger of different hormones as well, not only insulin, but the FSH and thyroid stimulating hormone. It is known, in fact, how its deficiency causes alteration in the response to these hormones, controls the metabolism of fats and sugars, and also regulates the cellular function of the nervous system. The folic acid is also required for the oocyte maturation and improving the quality of oocytes. And that its role doesn't need much emphasis because we learned it. And all guidelines, they also say the same for that particular fact that all this childbearing age should consume 400 microgram of folic acid daily. This will contribute towards the prevention of neural tube defects if woman gets pregnant, and 2 gram of myoinositol in combination with 200 microgram of folic acid twice a day with meals for 16 to 24 weeks of pregnancy is recommended by these guidelines. There was a search which was done electronically of all databases, the Medline and the Cochrane Library over from last 1 decade, and only the randomized controlled clinical trials were included to understand its role in the PCOS as well as the preconception management. All these search engine words were put to collect all the studies. Total 70 studies were identified. 49 out of 70 were excluded because of not involving myoinositol treatment in the women with PCOS. And the remaining 21 trials were considered eligible for this review. 6 of them were RCTs and met the selection criteria for this particular review. And what we actually understood by that, 4 trials evaluated the effect of combination of myoinositol plus folic acid administration on hormonal levels. In one trial, it evaluated the effects of combination of these 2 particular molecules in oocyte quality, and another one, data on ovarian function improvement after combination of myoinositol plus folic acid administration was reported. There were certain studies. This is a study 1 by Kenazani, where it was a randomized controlled trial for 12 weeks. The study was conducted where the women were treated with this combination of myoinositol in the folic acid, and the endocrine profiles were evaluated after treatment. The plasma luteinizing hormone, prolactin, LH follicle stimulating hormone ratio, and insulin levels significantly decreased. The conclusion was in patients with PCOS, myoinositol with folic acid is a novel therapy that ensures ovulation rate 72% and singleton pregnancy rate 40%. This combination improves insulin's action, ensures ovulation, and improves fertility. And that's why it plays a major role in the preconception management. The another factor which we know in those subjects of PCOS is the androgenic milieu. The study was done whether it reduces the testosterone, where the same combination was given twice a day for 6 months in 25 PCOS women of childbearing age. And the serum total testosterone value reduced from baseline 96 to 45 after treatment with these 2 combination, myoinositol and the folic acid. It also lowers BMI. Another 27 overweight obese PCOS were studied, combination was given, and the BMI value of 34.3 at baseline reduced to 31.2 after treatment with myoinositol and folic acid combination. Similar is the concern, as I told you in my first picture of the slide, the hirsutism, which could be very much distressing to all those young subjects. 50 patients with PCOS were enrolled in this study. They were given this combination and reported 44.4% reduction in the severe hirsutism cases. In 30% cases, hirsutism disappeared. It improves the lipoprotein profile as well, which is again important. We know that this lipid, they change a lot. There is good increase in the high density lipoproteins, and there is LDL which got reduced, as well as the triglycerides. The gestational diabetes is another common problem which we face in cases of PCOS. So all these 98 PCOS women, either with the combination of these two molecules or with metformin, were studied, and the prevalence of gestational diabetes in myo-inositol plus folic acid group was 17.4% compared to 54% in the control group, where only metformin was given. So people always thought, then does it really offers an additional advantage over metformin? Yes. The myo-inositol and folic acid increases PI3 kinase production, which is needed, which doesn't happen so with metformin. The insulin action is improved by 80%, whereby heat is improved only by 33.9% with metformin. Another study which was done by Costantino recruited 42 PCOS women patients after randomization, and 23 received combination and 19 received only folic acid. But there was definitely a good improved glucose tolerance in the combination group. After treatment, progesterone peak was higher in the combination of combined group compared to the placebo group. Significant reduction in the total serum testosterone occurred. Another study, which was done by Papalio, where 60 subjects undergoing ovarian stimulations were enrolled, and they were given either only folic acid or the combination of folic acid and the myo-inositol. Both the total recombinant FSH and the number of stimulation days were significantly reduced if we augment them by adding these two adjuvants. This resulted in significant lower number of cancer cycles because of hyperstimulation risk. In group treated with combination of myo-inositol plus folic acid, the number of immature oocytes and degenerated oocytes were significantly reduced. We all know that Professor Spiroff has told in the 1970s that these PCOS oocytes are incompetent as far as the reproduction is concerned. And that's why one need to address this issue by adding these two elements as an adjuvants to these particular patients before conception to have a proper understanding and proper results. The Gerli has studied 92 PCOS women to evaluate on the ovarian and the metabolic factors effect of myo-inositol. The 45 received combination and 47 received only placebo or the folic acid. The body mass index will decrease significantly in combined group. Circulating leptin consumption decline in combination of this particular myo-inositol plus folic acid group. Low density lipoprotein showed reduction, whereas the high density lipoprotein increased significantly in combination of folic acid and myo-inositol. We know of all about this Ponte study, which was very famous, which was for the prevention of neural tube defects by inositol. Reported the effectiveness of myo-inositol plus folic acid in the prevention of neural tube defects compared to folic acid alone in 117 women with the previous pregnancy with neural tube defects and when the new pregnancy was planned. So when we say about the inositols, the activities are at various levels. At the central nervous system, MI is essential for the development and function of the peripheral nerves. Osteogenesis is increased calcium in bone, increased strength and bone structure. Myo-inositol is essential to bone formation, osteogenesis and bone mineral density. The metabolism, the insulin sensitivity increases, reduces the HOMA index, decreases the glycemia, decreases the insulinemia, decreases the total and LDL cholesterol, increases the HDL cholesterol, decreases the triglycerides. When it comes to the reproduction, it restores normal ovulatory activity. Oocyte and egg quality gets improved, the fertilization is better, the sperm motility and mitochondrial membrane potential in vitro also improves a lot. There is good proposed selective serotonin reuptake inhibitor like role, and that's why the mood changes also makes a major difference. And it is essential for the growth and survival of cells That's why I need to give one preconceptionally. People again ask about what about the other actually the inositols like D-inositol, which also increases the glucose cell intake. It stimulates the glycogen synthesis. The myoinositol increases the oocyte quality. It has a similar role with D-chiro on insulin resistance, but no effect at the ovarian level. No direct effect on the fertility. Whereas myoinositol definitely reduces the amount of FSH used for the IVF cycles. It improves the metabolic and hormonal parameters in the PCOS, what we have noticed. So this was the rationale of combining actually both these inositols together as well, D-chiro as well as myoinositol, which can work at the periphery for the insulin resistance, for improving the glucose metabolism, improving the lipid profile, and reduce cardiovascular risk. Whereas for the ovaries, we need to have addition of the myoinositol. So in conclusion, after many years of attempts and uncertainties, there are now many consistent data which confirm the importance of myoinositol supplementation in association with folic acid in the prevention of neural tube defect. The safety of this prophylactic approach, given the lack of side effects associated with the periconceptional myoinositol supplementation. New studies could provide interesting data on the association of myoinositol and folic acid, even in normal pregnancy as well. I'm very sure the main purpose is to give a preventive advantage to all our women who come with a lot of hope in our consulting rooms. And I'm very sure our chairpersons, Yu Jung Han and Yusrawanti from Indonesia, will agree on this particular fact, and they will definitely consider to address on this particular issue of giving combination of myoinositol and folic acid in the preconceptional care. Once again, I must say big thanks to the organizers for this wonderful opportunity. And I'm very sure in the question answers, we can take these things for more discussion. Thank you very much.